I think we have numbers in at the moment, so we will begin. Good morning, everyone. Welcome to the Ridouts Summer Roundup. We have, over the last few months, had a number of webinars touching on issues around health and social care regulation and issues arising out of the pandemic. And what we're doing today is gathering up the most contemporaneous position and sharing that with providers, clients, stakeholders, anybody that's interested in the happenings around the sector. My name is Jenny Wild. I'm a director and a solicitor here at Ridouts, and we're delighted that you can join us today to speak of the issues that are happening right now and that are on the horizon for health and social care providers. We're joined today by my two colleagues, Samantha Burgess rather, who is joining us. She's an associate solicitor. She today will be speaking about the development of CQC's new strategy. And then we will be handing over to Solicitor Gemma Nicholas, who will be discussing the issue of mandatory vaccinations in the health and social care sector. Now, if you are interested in tweeting what we're discussing today, please feel free to use the hashtag RidoutsWebinars2021. We encourage as many questions as possible, so please use the Q&A box to submit any questions. And what we will do is look at those questions at the end of both talks, at the end of the session, so that we can have enough time to discuss the points raised. And after this webinar, we will be circulating a copy of the slides to all sign-ups. So, without further ado, let me hand over to my colleague Samantha Burgess, who is going to be discussing CQC's new strategy. Sam, over to you.
Thank you, Jenny. Thanks. Could I have the next slide, please? Thanks. Hi, yes. So today I'll be providing an update on the CQC strategy, including a very brief overview, an update on developments since the launch, and I'll also talk a bit about how providers can prepare themselves. Next slide, please. So this is what's happened with the strategy to date. So it was consulted on earlier this year. It was launched on the 27th of May, and since then, there's been ongoing public engagement as CQC starts implementing the strategy. We're now 2 months on since the launch, and CQC has been busy. They appear to be almost weekly developments at the moment, and I'll be talking about some of the latest ones today. Information on developments can be found through CQC publications, board meetings, and updates on the Citizen Lab public engagement platform. Can I have the next slide, please? Thank you. So this is a CQC pictograph summarising the strategy. So it's been split into 4 key strategic themes and 2 core ambitions, alongside some stated outcomes from the strategy, which are aspirational for CQC. So they've not been achieved yet, but as they continue to implement the strategy, this is where they're hoping to be. So I won't be describing the strategy in a lot of detail today. It's available on CQC's website. It's not very long and it's very high level, so there's not that much detail anyway. In CQC's consultation response, they acknowledge this and they've promised to work with stakeholders to develop the strategy, and this is what they're doing now. When reading the strategy, you'll see that it's got lots of language focused on working together and working with partners, and also words like developing, changing, and investing, which demonstrates that implementation is going to be a fluid process, and detail is slowly filtering through as CQC embark on steps for implementation. Now, unlike previous strategies, there's no clear target dates for achievement of the stated outcomes, but CQC are pushing forward fairly quickly at the moment with various actions. In general, the implementation appears to be much more fluid and open to change than previous strategies, and CQC appears to be consulting on and trialling new methods with a view to them being developed and improved as they go along. I also think it's worth mentioning here that the pandemic has had a really big impact on CQC's inspection methodology, with an almost overnight shift to risk-based inspections and analysis of remote data to inform inspection planning. So at the start of the pandemic, CQC was acting out of necessity, and they may not have had all the relevant technology in place to enable them to do this in the most effective way, and they've been developing the processes as they go along. And these changes that have been made to date are fairly in line with plans for the inspection landscape of the future as set out kind of vaguely in the strategy. So because of this, CQC are probably, and they have actually acknowledged this in recent board meetings, that they're probably further along than they would have been otherwise with changes to inspection methods as a result of the pandemic. Next slide, please. So I've just listed 5 key points that arise out of the strategy. So firstly, there's regulation driven by people's needs and experiences. So there's a big focus in the strategy of putting service users' voices at the centre of the regulatory approach. Now this brings about questions of where is the corroborating evidence? What will CQC be looking at to ensure opinions received are a true reflection of a service? Subjective opinion can't be the only basis to make a judgment, so we'll be keeping a close eye on how CQC applies this approach. And there's more remote data collection to inform inspection activity and ratings changes. So this means if providers want to make the best impression, they should make sure they have the systems to ensure they can easily draw out relevant data and also take care with how they present data to CQC. There's also going to be more frequent updates to ratings, and changes will not always be inspection based, as CQC want to be providing more up-to-date information and ratings to the public. So this makes me question, what will be the process for checks and balances? So currently we've got the factual accuracy process for physical inspections, and CQC is required by law to produce inspection reports from these. But what's going to happen when ratings are changed without a physical inspection? So will providers have the opportunity to challenge these new ratings? I don't have an answer to this, but I do hope there'll be some sort of remit to challenge in the future. Then there's a move towards risk-based inspections. So CQC will no longer be looking for good. So we may ask, will this mean that it's harder to achieve good or outstanding? If CQC are responding to risk, it's more likely they'll be looking at negative aspects and going in with a different mindset for inspection. And also we might ask, how can you move up to outstanding if you're already rated as good, if they're mainly focused on risk? And then there's a move towards shorter inspection reports. So CQC say that this is to make it easier for the public to digest, but it does raise concerns about generalised statements in reports that are notoriously difficult to challenge through the factual accuracy process, as it's unclear what evidence was used to support conclusions. And another question this raises is what other methods will be used to report back to the public for individual services. Could I have the next slide, please? So these are some initiatives being pursued by CQC at the moment in the implementation of the strategy, and I'll talk through each of these briefly now. Next slide, please. So from July onwards, CQC is introducing monthly reviews of the information they have on most services they regulate. So this indicates part of its plan to move away from the transitional monitoring approach that's been adopted during the pandemic to date. So this new approach is intended to help them prioritise their activity, and it will also involve publishing a statement on the provider profiles for lower risk services. So this is intended to let the public know that CQC has not found any evidence that tells them they need to reassess a rating or quality of care at a service at the time of review. And the quote on this slide is what the current published statement on provider profiles looks like if there's no concerns. And this falls under the report section of the provider profile. Next slide, please. So CQC have said that where they deem further information is required, they'll make contact with providers to take part in monitoring calls to gather more evidence about the quality of care in a service. They say these calls are not inspections and providers will not be rated afterwards, but here at Ridouts, we've been advising providers to treat them like a telephone-based interview. CQC have published a list of questions they expect to ask for each type of service, loosely based around the CLOEs, and these can be found on the CQC website. So as a result of these, CQC might still seek to carry out a physical inspection or proceed with enforcement action if they're told something during a call that concerns them. So at the moment, while calls might not directly impact ratings, we know that CQC are moving towards a more flexible approach to rating, so this could change in the future. There's currently very limited information available about this new method, but as CQC develops the approach, hopefully more detail will be made public. Next slide, please. So this is just a quick one to mention that CQC are currently seeking adult social care providers' experiences of sharing information digitally with CQC when inspectors have requested records. So there is a short survey live on the Citizen Lab platform at the moment that providers can feed into. Next slide, please. So the CQC is engaged in ongoing discussions about the development of a new assessment framework through its public engagement platform. So they believe the current framework no longer reflects the outside world, is hard to understand and is too long with lots of duplicates, so they're saying that they want to simplify it. Discussions are still in their infancy, but comments have so far been sought on the use of I, we and quality statements. And these are statements that have been developed using the current CLOE's prompts and ratings characteristics and are the wide-reaching, overarching statements based at the level of good. So the clear message coming out of discussion so far is that CQC wants to create a single new assessment framework that can be applied across all sectors, and it will continue to focus on the 5 key questions, but the existing CLOE's and ratings characteristics are likely to be replaced by a series of simpler, more succinct quality statements that link directly to the regulations, so making a bit clearer for providers as to what the minimum requirements are. And developments in this area seem to be being shared on the Citizen Lab platform at the moment. Next slide, please. So in the most recent CQC board meeting, Kate Taroney spoke about CQC's work around closed cultures and how they inspect services for those with learning disabilities and autism. And in line with this, the theme around people and communities, as well as the core ambition of equality, the CQC is looking at ways to really understand as best it can what it feels like for these individuals to receive care. So they've developed a new quality of life tool, and this is now being piloted in hospital inspections. But moving forwards, they've said they're looking to apply the toolkit to adult social care inspections of services for people with learning disabilities and autism. As far as I'm aware, the toolkit isn't publicly available and it's unclear whether it ever will be or how long it's going to be used for. But if anyone listening knows more about this, I'd be really interested to hear your experience. Next slide, please. So there's a bit of work being carried out around closed cultures at the moment. This is linked to CQC's latest COVID-19 Insight publication. So while the main focus of the publication was on data on COVID-19 deaths in care homes, alongside that, CQC also published information on what they've learned so far about how risk can accumulate and build in closed cultures based on a sample of inspections of, I think it was 29 independent mental health and adult social care services. So they've created a definition of closed cultures, and they want to raise awareness of warning signs so that providers and managers can take action if necessary. So the types of action that CQC have taken so far in response to identified closed cultures ranges from prompting a focused inspection to urgent notices of decision restricting admissions and arrangements with other bodies to find alternative placements for service users. So CQC action in this area can be very serious. Next slide, please. So CQC have listed some common features of closed cultures that are set out on this slide. I'm not going to read through them right now, but they're just here for your information. And next slide, please. So CQC have confirmed they're carrying out a year-long programme of work to transform the way it regulates services for people with learning disabilities and autism, with a focus on 3 key areas. So that's registering the right services, supporting providers to improve, and influencing improvement of care pathways. So that's the latest in relation to closed cultures at the moment. Next slide, please. So while there's still very little information on how exactly the strategy is being implemented, there are some things that providers can start looking at now to prepare for the imminent change. So firstly, you can make sure that you know your service. So you should be allocating the right people and resources to ensure you're aware of what's happening on the ground and can act quickly to address any concerns. There's a big focus on data sharing, so CQC is moving further towards remote information gathering and greater public sharing of data. There's a risk that some providers could fall behind if their systems are overly complex or not technologically advanced enough to keep up with changes in data sharing requirements. So you should be taking a look at how your systems are structured to allow you to extract and present data clearly to ensure that you're ready for these changes. Also, make sure you manage your inspection process, whether it's physical or remote. As we said, these telephone calls should be treated like remote inspections. You should be questioning, clarifying and challenging where necessary. And this is particularly important with monitoring calls where you will be the only impression that CQC get of the service. So do be prepared to respond to different types of inspections now. And feedback. So the strategy places a clear focus on the opinions and experiences of people who are involved with services. So that would include service users, their friends, their families, their advocates, your staff members, and also external professionals. So it would be sensible for providers to be proactive in reviewing how people feedback on their experiences within your service and how you collect that and take real ownership of this process. So you should be collecting and analysing feedback to inform your learning and development, and also keeping records of the feedback received and how you've used that to drive your service forwards and make improvements. And basically you need to be keeping up to date with developments over the coming months to ensure that you're aware of changes that could impact your services. We've already seen an unprecedented fast change in CQC's approach over the past year in response to the pandemic, and it's unlikely that things will be slowing down anytime soon in light of the new strategy. Can I have the next slide, please? Thank you. So yeah, in conclusion, implementation of the strategy is relatively fast moving and there are very regular developments. As I said, you should be keeping up to date with these, keep an eye on the provider participation platform, which is run by Citizen Lab, and the CQC website, and also tune into CQC's board meetings when you get the opportunity, because they're very up-to-date reports on what CQC is doing. It's definitely worth engaging with CQC's public collaboration efforts. This is the best way you can have a say in how you'll be regulated in the future. And finally, remember this is a learning curve for all involved, both CQC and providers, and there's a big emphasis on working together and building relationships. So you should be open to sharing your experiences of any changes, both positive and negative, to try and shape CQC's regulatory approach moving forwards. And yeah, that's the end of my talk, and I'll hand over to Jenny now. Thank you.
Thanks so much, Sam. That's really interesting and so much information there that's really important for all providers to consider. We've had a couple of comments in the Q&A box just to say, will we be able to circulate the slides? And just to reiterate that yes, we will be sending around a copy of the slides so that you can ruminate on all of the detail that Sam has discussed. I think that whilst plans are coming through from CQC thick and fast, what we've actually seen at Ridouts is the start of that process being implemented already, and inspections are becoming different. They're quite aggressive and they're coming from a slightly different perspective, and it is having an impact on providers. So we would be keen to hear if you've had a similar experience. And likewise, we've had lots of experience with challenging reports that we feel have not been fair because of the circumstances in which the investigation has been conducted. So thank you very much for that, Sam. Now, moving on to Gemma Nicholas, a hot topic at the moment, certainly, and we're getting questions about this almost daily. It's the issue of mandatory vaccinations. So Gemma, over to you.
Thank you. Thanks a lot, Jenny. Good morning, everyone. So as Jenny mentioned, I'll be covering the issue of mandatory vaccinations. Next slide, please. So I'm going to cover the change in legislation, what all of this means for providers from a practical and logistical perspective, and also the human resources aspect. Next slide, please. So the government consulted on and proposed that the law will be changed so that care homes can only deploy staff who have received 2 doses of the COVID-19 vaccination. The consultation ended in May, and it illustrated the battle between keeping those living and working in social care safe and the ethics of an individual's right to choose. Keeping those living and working in social care safe won the battle, and in June, the government announced that the coronavirus vaccination will be a condition of deployment in care homes. Not only that, the government is also planning on holding a further consultation on whether to make coronavirus vaccinations and flu vaccinations compulsory in the wider social care sector, including supported living and domiciliary care services. Next slide, please. So the reason for the change in the law stems from the Scientific Advisory Group for Emergencies advice that the vaccine rates of 80% in staff and 90% in residents in each care home setting would be needed to provide a minimum level of protection against coronavirus outbreaks. At the time of proposing the regulations, only 65% of care homes in England met that threshold, and the proportion was only 44% of care homes in London. Next slide, please. So who does this rule apply to? Whilst the consultation originally proposed that the rules would only apply to care homes with residents aged 65 and over, the new regulations will apply to all CQC registered care homes, providing the regulated activity of accommodation for persons who require nursing or personal care. And this applies to anyone coming into the care home in a work capacity, such as all full-time or part-time workers employed directly by the care home, those employed by any agency and deployed by the care home, support staff, and this includes staff who do not provide direct care to residents, such as cleaners and kitchen staff, healthcare workers, volunteers deployed in the care home, external tradespeople, including hairdressers and beauticians, and CQC inspectors. Next slide, please. So let's take a look at the new legislation. So the Health and Social Care Act 2008, Regulated Activities Amendment, Coronavirus Regulations 2021, comes into force 16 weeks after the day on which they were made. So I'll come back to the timescales in a second, but for now, you need to note that the amendment regulation amends the Health and Social Care Act 2008, Regulated Activities Regulations 2014, which you will be familiar with. And it inserts the requirement as a new provision in the fundamental standards in Part 3 of the regulations. Next slide, please. Regulation 12, which deals with safe care and treatment, will be added to, specifically Regulation 12.2H, which you will see on the next slide. It states that in order for a provider or registered manager to provide care and treatment in a safe way for service users, they must assess the risk of and prevent, detect and control the spread of infections, including those that are healthcare associated. And at the end of Regulation 12, after paragraph 2, new paragraphs will be inserted as shown on the next slide. So there are more new paragraphs than this, but these on this slide are the most relevant for this discussion. So these new paragraphs effectively expand on paragraph 12.2H. And as you can see on the next slide, they state that a registered person, and so a registered person being the provider or registered manager, must secure that a person, B, does not enter, sorry, the lights turn off, does not enter into the premises used by A unless B is a service user, B has provided A with evidence of being vaccinated or evidence of a clinical reason they should not be vaccinated. And on the next slide, B is providing emergency assistance in the premises, or B is providing urgent maintenance, maintenance assistance. B is the emergency services, or is a friend or relative of a service user. Is visiting a service user who is dying. Is providing comfort or support to a service user in relation to the service user's bereavement following the death of a friend or relative. Or B is under the age of 18. Next slide, please. The amendment to Regulation 12 also states a registered person provided with information as evidence may process that information, and nothing in the regulation authorises the processing of the personal data to be in a manner inconsistent with data protection legislation. So as you can see, the amended Regulation 12 covers a number of points. It covers timescales of the new regulation coming into force, exceptions and exemptions, as well as data protection. I will cover these points in more detail in a moment. However, I would first like to highlight that, as shown on the next slide, the Health and Social Care Act 2008 Code of Practice on Infection Prevention and Control and Regulated Guidance has been amended also. So providers must have a regard to the code when complying with their obligations under Regulation 12. Draft amendments to the Code of Practice were published alongside the consultation at Annex A. And the main thing to highlight with the amendment to the code is that it states that for staff who are unable to be vaccinated due to health reasons, registered managers or the equivalent person will have completed risk assessments and taken appropriate actions to mitigate risks. So bear in mind, this is another practical step that needs to be implemented by providers in the coming months. Next slide, please. So moving on to timescales, there initially was confusion about when the new law would come into force and when the 16-month grace period would begin. Sorry, it's actually 16-week grace period. But we now know that the 16-week grace period started on the 22nd of July. The regulations come into force on the 11th of November. So the last date that for care home workers to get their first dose so that they are fully vaccinated by the time the regulation comes into force is the 16th of September. So this timetable should hopefully give providers and staff enough time to arrange to have both doses before the law changes. Next slide, please. There is a difference between exceptions and exemptions. As mentioned, there will be exceptions for visiting family and friends, under 18s, emergency services, people undertaking urgent maintenance work or providing emergency assistance. However, only staff with a prescribed medical exemption are not required to be fully vaccinated. According to the consultation and outcome publication, a small number of people will fit into this category. Further details are yet to be outlined in guidance, but it is known at present that the guidance will reflect the Green Book on Immunisation against Infectious Disease and clinical advice from the Joint Committee of Vaccination and Immunisation. Please note, staff who are pregnant, breastfeeding or trying to get pregnant are not exempt unless they have a medical reason not to be vaccinated. Furthermore, the Department of Health and Social Care has confirmed that there will be no exemption for staff who object to vaccination on religious grounds. Next slide, please. There will be data protection implications where employers require staff to confirm their vaccination status. Providers should think about how they will record proof of vaccination and also medical exemption, and whether their processes comply with data protection legislation. So such data will amount to special category personal data and is subject to stricter regulations. Therefore, providers should exercise greater caution when processing this data. If you have any queries regarding the processing of special category personal data, the Information Commissioner's Office website has a helpful guide, and there is a link to it in the slides. Next slide, please. So what does this mean for providers? So there is the day-to-day practical impact of the proposed new law and the long-term impact on the sector. Let's start by looking at the day-to-day impact. Next slide, please. So the day-to-day impact has been described as a logistical nightmare and an unworkable door policy. Care homes will now be responsible for checking the vaccination status or exemption of every person crossing their threshold, including agency staff. And this is on top of ensuring that existing staff have their vaccinations in time to meet the end of the 4-month grace period. Providers need to think about the practicalities and logistics of managing this change, which can include updating company policies and procedures, updating contracts with external suppliers to include a vaccination clause, adapting recruitment processes, the administrative side of checking and recording the vaccination status of those coming into the home, and evidencing compliance to the CQC. Next slide, please. The requirement for those working in a care home to be vaccinated will be monitored and enforced by the CQC. Reported vaccination rates will therefore form part of the suite of information the CQC considers when determining which care home the CQC inspects. In the case of non-compliance, the CQC can use its civil and criminal enforcement powers. Civil enforcement powers are listed on the slide and include the issuing of warning notices, notices of proposal and notices of decision, as well as urgent action. In the most serious of cases, providers may face criminal enforcement action where a breach of Regulation 12 results in avoidable harm or a significant risk of avoidable harm to a service user. Criminal enforcement action could result in prosecution or a fixed penalty notice of £4,000 for the provider and or £2,000 for the registered manager. Next slide, please. So with all of this, it's important to take a look at your business and your services and consider what is the current uptake like? How many staff have been vaccinated? Which staff will be affected by the new legislation? Which staff have not been vaccinated? Which have only received 1 dose? Which are likely to be exempt, and how will this exemption be evidenced? Next slide, please. I would say the starting point is to encourage employees to get vaccinated. Find out which staff are still to be vaccinated and what their reasons or concerns are for declining. Maybe ask staff who have been vaccinated to share their experience with others. Invite medical professionals to talk to staff about their concerns. But most importantly, use this grace period to push education about the vaccine and to try to encourage voluntary take-up. Effective communication and engagement with staff is key, especially as boosters will also have to be taken, not just the initial vaccination. And it is ideal to have properly engaged staff rather than having to coerce staff every year. Also, when communicating, be very clear on what it could mean within the new legislation if a staff member chooses not to get vaccinated. Vaccine enablement is also essential. It's about enabling staff to get vaccinated within work time, offering opportunities for staff to get vaccinated without losing pay, making sure that staff are not penalised should they experience side effects and need time off. Next slide, please. The new law may come as a relief to some providers who wanted to impose mandatory vaccinations but feared employment claims. However, the legislation does not completely remove the risk of employment claims. Employers still need to be sensitive to individuals' concerns, act reasonably, and follow a fair process. However, the new law provides a statutory framework to require vaccinations where reasonable attempts have failed and provides a stronger defence where workers are redeployed or dismissed when they have failed to be vaccinated. The slide here provides a few considerations for some of the protective characteristics. For those who are medically exempt, employers will need to treat such cases with caution and avoid discriminating against those who may be suffering from disabilities or serious medical conditions. In addition, as there are very limited medical exceptions and no exemptions on the grounds of religious beliefs, providers need to ensure that they are fully prepared for a potential rise in unfair dismissal or discrimination claims. Next slide, please. Employees with at least 2 years continuous service have unfair dismissal rights. Employers are therefore exposed to unfair dismissal claims if they have not followed a fair process or do not have a very good reason for dismissing because the employee has refused the vaccination. An employment tribunal would need to consider whether disciplinary action or dismissal of an employee was a proportionate response to the refusal to be vaccinated. Therefore, providers would still need to show that they have taken into account the reasons behind any refusals and especially taken proper account of the reasons based on protected characteristics. Providers will need to show that they have considered alternatives to dismissal, such as redeployment or altering the employee's role, that any concerns raised have been properly considered and documented, and that a fair process was undertaken before dismissal. Next slide, please. Touching upon the long-term impact, we should take note that over 60,000 people signed a petition against the plan by the government to make the coronavirus vaccine mandatory for care home workers. There are likely to be a high number of unvaccinated staff who would not be exempt and are unlikely to be persuaded to be vaccinated when it becomes mandatory. Also, there are reports that many staff in the sector would rather quit than receive the vaccination. If high numbers of staff continue to refuse to be vaccinated, there is a real risk that significant numbers of staff will leave their jobs and the existing challenges with recruitment and retention in the sector will worsen. Next slide, please. So by way of conclusion, looking at the three areas we have covered today, the key points are, in relation to change in legislation, the regulations come into force on the 11th of November. The deadline for the first jab is the 16th of September, and only staff with a prescribed medical exemption are not required to be fully vaccinated. What does this mean for providers? We looked at, obviously there's the logistical aspect of applying the new law to existing staff, new recruits and visiting professionals, as well as being able to evidence compliance to the CQC. We also looked at the human resources aspect, and the top tips are to do an internal audit of your company, use the grace period to engage with your staff, aim for dismissal being a last resort, and most importantly, operate a fair, well-documented process that ensures sensitivity to individuals' concerns. That's all from me. Thanks a lot for listening.
Gemma, thank you so much. That's really helpful and something that's a massive change for providers that we all have to get used to. As I'm sure you can all imagine, we've had a ton of questions through, so I'm going to fire a couple at both Sam and Gemma. If we don't cover your question today, then we will be reflecting on everything that's been submitted in the Q&A box and uploading that to our website after the webinar. So starting with you, Sam. Someone has asked, what kind of changes can we expect to be made in relation to physical inspections?
Hi, thanks, Jenny. Yeah, it's a good question. In terms of physical inspections, the strategy acknowledges that they are a vital part of their performance assessments, and it's still essential to be observing the care that people receive. But they also acknowledge that physical inspections are not the only way to assess quality. So we've noticed already that CQC is moving towards more remote collection of data to inform its inspection activity. So the strategy says that that inspectors will be spending less time looking at paperwork during physical inspections and will instead be spending more time speaking to people who live in or use services, their families, advocates and staff members, as well as carrying out direct observations of care. So it's less likely that providers will be having an inspector turning up and locking themselves in an office all day looking at records. They'll be have more of a physical presence during the inspection and be moving around the service more. That's not to say that you won't be receiving requests for documentation following an inspection. In fact, I would imagine that such requests might increase to allow inspectors to follow up on direct observations. So for corroborating the evidence that they've collected during the inspection process through looking at paperwork. CQC has been clear that inspections will be more targeted and only carried out where there's a clear need to do so. So, for example, responding to risk, or where they've only received limited amounts of data. And as I said earlier, CQC inspectors will no longer be required to be looking for good. So it's more likely that during a physical inspection, the inspector may seem to have a preformed idea about the quality of a service. And so providers may need to be working even harder to change their minds, presenting evidence of positive care provision and experiences.
Thanks, Sam. One of the participants has asked in a similar vein, whilst developments is a good thing, what do we think would be the impact of less of a CQC presence on site? And I guess you've just touched on that. Is less of a chance for them to see positive interactions between service users and staff? That's the care element of care, and it seems like CQC are forgetting about the fact that care is at the very root of what is being provided, and a lot can be missed without being there and witnessing it firsthand. Would you agree?
Yeah, definitely. And so, yeah, as I say, providers are going to have to sing for themselves more, particularly in relation to the documentation or evidence that you may be required to send over to them in the future. You want to be showing the good things that you're doing, because they won't be observed. And in the same regard, negative aspects of care might not be observed so easily, and so CQC are going to have to make sure that they properly develop their information collection processes to ensure that things don't get missed that could potentially have been picked up better during physical inspection.
Thank you, Sam. And for you, Gemma, someone has asked, can providers ask prospective employees about their vaccinations?
It really does depend. So whilst it is a requirement for all workers to be vaccinated, and that's according to the Equality Act, whilst it's a requirement for all workers to be vaccinated, you've got to think of the Equality Act, because there is a general prohibition on asking about the health of applicants prior to an offer being made. So providers should take specific legal advice on this, but note that a job offer does need to be made before you can ask that question.
Thanks, Gemma. And someone has asked, a lot of this guidance and the news about the vaccinations appears to just apply to care homes. Does it also apply to other types of care providers, for example, private ambulance services or domiciliary care, or are we still waiting for that?
Yeah, we are still waiting for that. So at the moment, the government obviously had the consultation on this for care homes, and they're now consulting on it for domiciliary care agencies and the wider sector, really. So I'd say keep an eye out for the consultation. And it's not just to remind you, it's not just the COVID vaccine as well with this most recent consultation, it's also the flu vaccinations as well. So it is growing, it's getting wider.
Thanks so much, Gemma. And thank you to both you and Sam for your really detailed presentations today. I'm glad that we've been able to share this with people, and they've had lots of questions, which shows a lot of interest and I wouldn't say concern, but trepidation about where we're headed, really, and how providers need to start to get prepared. So thank you both, and thank you everyone that's joined in the webinar today and participated. Just to remind you that the slides will be circulated. Any questions in the Q&A box that we have been unable to answer will be reflected on and uploaded onto our website. If you have any comments or anything you'd like to share via Twitter, then you can find our handle at Ridouts Law. You can connect with us on LinkedIn. And if you want to review this webinar and other webinars in our series, then do feel free to have a look at our YouTube channel, which can be found under Ridouts Professional Services Limited. Thank you all for joining us. We've had a very difficult 18 months as a sector, and the challenge still changes, it still grows. But if you have anything that you'd like to contact us about, please have a look at our website, link with us there. There are lots of articles and information about the changes that are happening, as well as other things to do with regulatory law that you might find useful. And that's all from us. So thank you for taking the time this morning, and we will be in touch soon with our next webinar. Thank you all.